Hello, dear audience. Today my talk is devoted to managing of osteoporosis and mitigating the risk of osteoporosis in menopausal women. So again, according to reproductive aging workshop, which was designed in 2001 and then reviewed and changed in the 2011. Menopause is the final menstrual period of the woman or in women, and 12 months afterwards is diagnosed and concluded retrospectively. The menopausal syndrome is the group of the symptoms that women experience becoming menopausal. The perimenopause is time after a final, perimenopause is the time before the final menstrual period when woman starts to experience menopausal symptoms. Due to estrogen decline and imbalance in follicle stimulating hormone rise, so due to imbalance of the hormone that starts, usually they start to experience the irregular menstruation, but some of them may not and still can regularly menstruate. The postmenopause is the period of time in a woman's life after final menstrual period and until the rest of her life. There is also such a nosology or pathology such as iatrogenic menopause, the one that is related to surgical removal of the ovaries or the shutdown of their functioning due to radiotherapy or chemotherapy or hormone related therapy treatments. This is actually the chart, the stages of reproductive aging workshop. The one I mentioned was reviewed in 2011. So you can see that the perimenopause is the time, like I said, when women start to experience the menopausal symptoms and hormonal imbalance. And also it covers the very early, like 1 year of the postmenopause. So though this 12 months after final menstruation. What is happening in reproductive system of a woman while she starts to age? What kind of processes? First, it's a loss of the follicles, ovarian loss of the follicles, the depletion. Yesterday I showed you the picture that every month is around 3 to 50 primordial follicles are being recruited to grow into the antral and preovulatory follicles. So only 1 or 2 of them become mature and the rest undergo atresia. So let's say when women become by the puberty and having around 200 or 300,000 of the oocytes, it's the oocyte vault, the so-called reserve of the woman. So by the time of menopause, 50, 51, 52 years old, this pool of oocytes almost depleted. So and of course, the production of the hormones by the cells of follicles, granulosa cells, and cumulus cells also shuts down. The production of the hormones, which actually totally undergo the haywire by the time of menopause. Women experience the drastic drop down of the progesterone because already since the perimenopausal time, most of menstrual cycles become anovulatory. So no ovulation, no corpus luteum, no synthesis of progesterone. So most of the symptoms, first of all, are caused by the drop down of the progesterone, such as sleep disturbances, the mood swings, psycho-emotional mostly symptoms related due to drop of the progesterone. Another thing, estrogen also undergoes the sharp decline. Inhibin B, this hormone together with the estrogen provides the negative feedback loop to hypothalamus normally. But by the time of menopause, the pituitary starts to produce, ramp up the follicle stimulating hormone, and there is no more tissue or cells that can respond to the stimulation by synthesizing of estrogens and inhibin B into follicular phase. So inhibin B is also one of the important markers of depleted ovarian reserve, same as estrogens. Testosterone. Testosterone in a female body produced by the ovaries and adrenal glands and also peripheral tissues. So the loss of testosterone, the androgens, not only testosterone, DHA also, is going more gradually. So the symptoms like loss of libido or loss of sexual arousal and all, so all these sexual dysfunction symptoms women start experience a bit later in the postmenopausal period of time. Yesterday I also already mentioned this, that the normal menopause or timely menopause comes in the age of 45 to 54. After 55 is considered as the late menopause, 40 to 45 is early, and before 40 is premature menopause related to the premature ovarian insufficiency, premature ovarian failure. The symptoms of menopause, I would like to emphasize the musculoskeletal, the one that related to loss of the bone mass, such as osteopenia and osteoporosis, the symptoms, pain in the muscles and bones. Sometimes it can be the only one complaint that women the reports at the GP's visits, for example, and it can be related due to the estrogen decline, whether it's time or premature menopause starts. So this pain can be disabling. So it's not just some mild pain in the joints and muscles. It can be quite severe. So impairs seriously and lowers quality of life. Postmenopausal osteoporosis is one of the most common types of osteoporosis that ever exist. And in the age after 50 years old, more than half of women are in the risk to develop osteoporosis. This statistics is quite impressive compared to the male statistic. In men, only 1 in 5 men would have the high risk to develop osteoporosis due to andropause, for example. So what is osteoporosis? Is a systemic skeletal disease that is characterized by the decrease of the bone mass, low bone mass, and also deterioration in the microarchitecture of the bone that leads actually to high susceptibility to the bone fractures and bone fragility. What is the pathogenesis of osteoporosis in postmenopause? Is the prevalence of the bone resorption process over the bone formation. So the structure of the bone changed in a way that there is a loss, especially in the early menopause, like first 5 to 8 years, early menopause. There is a loss of trabecular mass of the bone. In men also this happened totally different. That is why the age-matched peers, for example, they do not experience they experience same change after 10 years. So in the age, let's say woman has this change in the 50s, men in the 60s. It's all can be explained by the structure of the bone, first of all, and testosterone influence, testosterone effects. So what is happening? Loss of the trabecular bone due to loss of connectivity and also loss of cortical bone due to porosity and thinning of the cortical bone mass. The most common or the most, how you call it, let's say the most common types of the fractures that happen in postmenopausal women, it's a fracture of the hip, of spine, of distal radius, and shoulder. The process is contributing to the increase of osteoporosis in postmenopausal menopausal women. First of all, is the estrogen decline, because estrogen play extremely important role in the bone remodeling processes. Imbalance in the bone remodeling itself is happening also due to rise of inflammation, due to a rise due to impaired immune system and other aging processes apart from the estrogen decline that causes the imbalance in bone remodeling. Impaired absorption of the calcium in the intestine. The absorption of calcium in intestine is promoted by estrogens. Vitamin D3, its natural depletion with the age is happening, not related even to hormonal decline. So we always should be bearing in mind and check the levels of vitamin D3. Sarcopenia, loss of the muscle mass. Yes, of course, loss of mechanical load on the bones also play crucial role in the developing of osteopenia and osteoporosis. Increased fat mass. Increased fat mass in the other hand, promoting the chronic low-grade inflammation. On the other side, it works protectively in women menopausal and postmenopausal. So let's say women who have excessive weight, they might be partially protected from the osteopenia and osteoporosis development in the menopausal, postmenopausal time. Why? Because the excessive amount of subcutaneous fat is actually the place where the process of aromatization, conversion of the androgens to estrogen is happening. So these residual circulating estrogens, they work protectively. Decreased renal function. Decreased renal function lead to poor activation of vitamin D. So vitamin D is responsive for the absorption of calcium in the intestine as well, and other effects. Bone remodeling. In a nutshell, in our body, during the lifetime, the process of bone turnover, bone remodeling is happening all the time. To repair the micro damage, to adapt our body to the changing mechanical and metabolic needs. So bone resorption and bone formation are two processes that are supposed to be balanced in a way to preserve the bone mass. We have two types. Most of cells in a bone, like 95%, is osteocytes. Okay, and the osteocytes they work as mechanosensors and give the signals to osteoblasts and osteoclasts to reduce or to increase the bone mass. The cell precursor of the osteoblasts is mesenchymal stem cell. And their differentiation, survival, and growth of osteoblasts is dependent on the estrogens, including estrogens, okay? There is in this picture, I did not highlight it, but the so-called, maybe I believe you know, because most of you are doctors, the WNT signaling pathway in our body. So WNT stands for Wingless related sorry, Wingless related site, signaling site, let's say. So it's a group of the genes that produce important proteins taking part in the bone remodeling, playing a crucial role in the bone remodeling and the activation and survival of the osteoblasts. And also, at the meantime, bone cells, osteoblasts, osteocytes, they produce proteins such as oh, sorry, the one that blocking this pathway. Sclerostin. That is why there is a therapy based on sclerostin blockers, monoclonal antibodies. Later, also, I will tell more about this. So. Another mechanism is receptor activated nuclear factor kappa B, RANK, the so-called abbreviation RANK. So this receptor is on the surface of the osteoclasts and is its ligand, which is rank ligand, when it binds to this receptor, so it activates the promotion and differentiation of osteoclasts. That is why promoting the bone resorption process, okay? And there is also osteoprotegerine. It's a bone protecting protein which is produced by the osteoblast and osteocytes. So estrogens are in a way ruling the production of osteoprotegerine protein. And later on, the drop of estrogens crucially impacts the process of bone resorption and bone formation, activating and blocking responsively these ways. The osteoclasts, those cells deriving from hematopoietic cells of monocyte and macrophage lineage. So you can see it's an orange color. It's in the end, osteoclast. It's a multinuclear cell, the one that has rifled edge, increasing its surface, the one that binds or seals to the surface of the bone and produces a lot of hydrochloric acid, the one that create perfect acidic environment for the enzyme catepsin B, the one that dissolves collagen type 1 in a bone, resorbing or degrading the bone, literally saying. So this is two pictures, left and right. You can see what is happening in the bone with estrogen and in case of the estrogen deficiency. So green color, the estrogen, you can see. First of all, estrogen inhibits the formation and differentiation of osteoclasts. Okay, this is number one mechanism. Number two mechanism, estrogen promotes the synthesis of osteoprotegerine, the one that work as a decoy for this binding reaction of RANK ligand to its receptor, the one that activating the precursor of osteoclasts. And as I said, the estrogens, they promoting the synthesis of bone protecting protein, osteoprotegerine. This is mechanism number two. Mechanism number three, that estrogen block sclerostin, the one that appears before I mentioned this, appears to be a blocker for WNT signaling pathway activator of the osteoblasts. So minimum three mechanisms how estrogen important for the bone formation and inhibiting bone resorption. As I mentioned, the key mechanisms: estrogen inhibits osteoclastogenesis and promotes osteoblast survival, increasing osteoblast activity and decreasing osteoclasts. So again, just to sum up the key pathways, how estrogen is important for the regulation of the balance between bone resorption and bone formation. The estrogen deficiency results in decreased osteoprotegerine synthesis, decreased apoptosis of osteoclast, suppressed Wingless-related signaling pathway due to high sclerostin expression. Also, there is at the meantime, due to estrogen decline, there is a natural rise of the inflammatory cytokines such as tumor necrosis factor, interleukin-1, interleukin-6, and rise of the oxidative stress. Increased apoptosis of osteoblasts, also as a result of the estrogen deficiency. And on the other hand, estrogen make osteocytes sensitive to the changing mechanical load. So mechanosensing, the process of mechanosensing is also promoted or strengthened by the estrogens, and also very important. There are a lot of studies and experiments was done on the animals, on rats, where they totally switch off the estrogen beta, type beta mostly, receptors, and there was no response in the activation of the bone formation, because the mechanism of mechanosensing by the osteocytes, like I said, is mediated by estrogens. So the key risk factors for osteoporosis in peri and postmenopausal women. First, it's estrogen deficiency, yes. Advanced age after 50 years old. Early menopause or iatrogenic menopause, surgical or radio or chemotherapy or hormonal therapies related. Low body weight, body mass index below 19. Simply, there is no mechanical load on the bones. So yeah, definitely not recommended to lower your weight to the low body mass index like 19 and below. Family history is important, because up to 70% of the bone formation genes, the one that promote bone remodeling, are 70% are inherited. Rheumatoid arthritis, Caucasian or Asian ethnicity, hyperthyroidism, hyperparathyroidism, chronic kidney liver disease, gastrointestinal disorders, diabetes, especially diabetes type 1, medication use, glucocorticoids, anticonvulsants, proton pump inhibitors, selective serotonin reuptake inhibitors. So there is a range of medications that can promote the osteoporosis. History of previous fractures, lifestyle factors, less of physical activity, and non-adequate or low intake of calcium and vitamin D3, poor diet, malnutrition, let's say, and low peak bone mass. What is peak bone mass? We know it's the highest or the biggest amount of bone mass that we can have during our life, right? Usually by the early adulthood, we have the highest amount of accumulated bone mass. And starting since 30, 32, 35, we experience the natural loss of bone mass. So the higher peak bone mass you have by the early adulthood, the less you are predisposed to develop osteopenia and osteoporosis. So it's like your bone reserve, let's say. This is the full full list of diseases and medications that may cause secondary osteoporosis. So it's quite extensive, as you may see. The one that I listed just now before is only like common and known. Yeah. Clinical indicators for osteoporosis in peri and postmenopausal women. For example, physical signs, height loss 4 cm, but even 2 cm and more already is a physical sign. Kyphosis or stooped posture, chronic back pain due to vertebral fractures. Vertebral fractures are happening the first among the others osteoporosis related fractures in women, as I said, due to loss of trabecular bone in the early menopause. Reduced mobility and function. What are the diagnostic clues? Dual energy X-ray absorptiometry is the golden standard for the diagnosis of osteoporosis or osteopenia. But now we know, and I believe Dr. Olga before in other lectures mentioned about the Ecolight technology, REMS, which is radio frequency ecography multi-scanning, and it's ultrasound based, which is also quite accurate to measure bone density. High FRAX 10-year fracture risk, or also later we talk more about the FRAX. Low serum vitamin D and increased level of bone turnover markers. What are the red flags to send your patient to check the bone density via any way? Either it's a DXA or either it's a Ecolight. Fragility fracture and more than 2 clinical risk factors present: height loss and chronic back pain. So the criterion of osteopenia is T-score. Actually, T-score is a score that measured on the 2.5 deviations below peak bone mass is considered as osteoporosis. Deviations 1 to 2.5 is osteopenia, low bone mass. We all know this. T-score is a deviation to younger adult, like a comparison to younger adult. We also have another parameters such as Z-score, which is the adult age-matched peers comparison. Ecolight, as I said, radiofrequency ecographic multispectrometry. Radiation-free, and it's new, and it's portable and easy to maintain, and as I said, also very accurate compared to DEXA. No need to any protecting shields, no need any extensive maintenance, no need for, it's quite fast. This diagnostic is quite fast and quite easy. So I think later on it will replace the X-ray based densitometry. Fracture risk assessment tool. There are also other assessment tools for to measure the risk of 10 years fracture. But nowadays, mostly used is a FRAX calculator. It's easily accessible on the website. Anyone of us can go and check your risk of 10 years fracture. Based on individualized models that integrate risk of associated and clinical risk factors. So, and it evaluates 12 parameters. It can be done only for persons aged 40 to 90 years old. gender, weight, height, previous fracture, parental fractured hip, current smoking, glucocorticoids use, rheumatoid arthritis, secondary osteoporosis, and alcohol 3 or more units a day. 3 or more units a day is 1 unit is equivalent to 10 milliliters of pure ethanol. So 3 units is 3 units is a bit more than 1 glass of wine. Around 1 glass of wine, 200 ml, something like this. So if every day you consume one glass of wine, you are in the risk to develop osteoporosis and fracture. So two outcomes you receive after undergoing this calculation. Major osteoporotic fracture, it's like a common risk of the hip, spine, wrist and shoulder, and also separately the hip fracture. This is the chart of parameters, normal and abnormal. So low risk is below 10% for the major fracture risk, and below 1% for hip fracture. Moderate 10 to 20, and for hip fracture 1 to 3%, and high risk is for major fracture risk more than 20%, for hip only more than 3%. It's when you are in the high risk, so it's a sign to take action and start treatment, actually. Anti-resorption therapy. Bone turnover markers. They are used to evaluate the rate of bone resorption process in your body. Okay, there are markers of bone formation and markers of bone resorption, but routinely this test is not used. Cost related, and also it mostly used for the research and to maintain or to see the effectiveness of the treatment of anti-resorption therapy. In that case, you probably would prescribe the bone turnover markers. So the most used are two. The marker CTX, the so-called beta-cross labs, and among the markers of bone formation, it's a procollagen type 1 and terminal propeptide, P1 and P. Sometimes also osteocalcin. Osteocalcin is the protein that is synthesized by osteoblast. Osteoblast together with collagen 1 type 1, osteocalcin, osteonectin, osteopontin, all these proteins that we have in our bones produced by osteoblasts. As I mentioned, in postmenopausal women, in which cases we ask to do this test. If we would like to see whether the process of bone resorption outpace the bone formation in women, so fast loss of bone mass. If we would like to check whether women have this, right, to monitor the response to the therapy and to predict fracture risk. But also, mostly the FRAX bone measurement, bone density measurement is totally sufficient already to decide whether you prescribe treatment or you not prescribe any treatment, or how you monitor this patient. How do we manage this patient, okay, postmenopausal? In case if there was not yet any fracture in the age after 50. So if the T-score, if minus 2.5, if they diagnosed osteoporosis, so we immediately initiate the treatment with osteoresorption medications or hormonal replacement therapy. If there is a after bone density measurement, if we reveal osteopenia, and FRAX outcome is more than 3 or more % for the hip fracture, and for the major osteoporotic fracture more than 20 or above. If our lady already had in the after age 50 fracture, right? So already, regardless of bone measurement densitometry, I mean, regardless of the results of densitometry, we still prescribe the treatment. There are medications or remedies to treat osteoporosis. Of course, it's a hormonal replacement therapy. It's number one for women. Either is estrogen alone, either is combined estrogen with progesterone. Depends on the presence, uterus is present or removed. Okay, bisphosphonates. Bisphosphonates, the mechanism of their action lies in they can bind the calcium hydroxyapatite. It's a main mineral in our bones. So they bind to calcium hydroxyapatite and been absorbed by the osteoclasts, which is a bone macrophage. It's not dissolves inside of the macrophage, so it accumulates in the bone and stays there. This is the mechanism how bisphosphonates work. What to pick, bisphosphonates or hormonal replacement therapy when you have on a visit your menopausal woman with osteoporosis, right? It depends on the symptoms, other symptoms of menopause. If she report the vasomotor or vulvovaginal atrophy symptoms or psycho-emotional, so of course you will go with hormonal replacement therapy directly. In the absence of the symptoms, you will go with bisphosphonates. So as per the guidelines of Osteoporosis Foundation, Bone Health and Osteoporosis Foundation, number one choice is still bisphosphonates. In case if woman cannot take bisphosphonates, second line will be hormonal replacement therapy. But again, it depends on menopausal symptoms presence. Parathyroid hormone analogs like teriparatide, abaloparatide, selective estrogen receptors modulators, raloxifene, bazedoxifene also appear to be effective. Monoclonal antibodies, the RUNC ligand inhibitors. Remember when I was talking about the mechanism of bone remodeling? So inhibiting the differentiation and proliferation of the osteoclasts, literally inhibiting bone resorption with the help of denosumab monoclonal antibodies. Sclerostin inhibitor, the romosozumab also is quite effective. And calcitonin salmon, it's a recombinant calcitonin, the one that derives from a salmon, appear to be more effective than recombinant human calcitonin. There are no uniform, like no one size fits all. There always should be an individual approach when you treat postmenopausal, menopausal osteoporosis in women, okay? So after, for example, 5 years taking bisphosphonates, your patient is on the bisphosphonates, you're supposed to reassess, or 3 years of intravenous bisphosphonates. So you're supposed to reassess and put on a drug holiday, the so-called your patient. Of course, if the T-score will be below minus 2.5. Recommended one every year or every 2 years to perform bone mineral density measurement. Universal recommendations. First of all, it's adequate calcium intake. For women 50 years, around 50 years, recommended dosage of the calcium is 1,000 milligrams. For women above this age, already 1,200 milligrams. To excess this amount, I mean, to take more than 1,200, like some doctors prescribe 1,500. Put your patient in the risk of kidney stone formation. So not recommended. 1,000 is totally enough. At the meantime, you're supposed to give recommendation in terms of the diet rich in the calcium. So dairy products, and dark greens consumption is recommended on a regular basis. Adequate intake of vitamin D to maintain its level 30 to 50 nanogram per milliliter. Supplements or sun exposure, but supplements I think is the best option. Cessation of the tobacco use and alcohol intake is recommendation also number one. As I mentioned, it's one of the risk factors, the alcohol consumption and nicotine for osteoporosis. Regular physical exercises, weight-bearing resistance training, also recommended, and it's supposed to be not like light physical activity. It's supposed to be like normal and adequate training, 2-3 times a week of resistance training, either with your own weight, either with the weights in a gym, for example. So to promote good bone mass, to provide the mechanical load on your bone, you should pump your muscles and try to achieve muscle hypertrophy to have bone muscle mass, to prevent sarcopenia. Prevention of the falls. So to recommend patient be very cautious, and if she has poor vision, like to change the glasses or go to evaluate to optometrist or whatever. At home, be very careful. And a weight drop of the weight. So slim those women who like slimming, please do not abuse much on this. Because you put yourself in the risk of fractures, which is way more serious than any aesthetic effects, okay? Regenerative treatments, of course, number one, it's mesenchymal stem cells, that since they are a precursor of osteoblasts. Mesenchymal stem cells can be adipose derived, can be bone marrow derived, or Wharton jelly, or cord derived. So any mesenchymal stem cells are good, including xenogeneic, for example, the one that we practice. And also we see quite good result in patients who have problems with musculoskeletal system when we administer them mesenchymal peptides or mesenchymal stem cells. After that, they experience quite an improvement. Or if injected periarticular, for example, together with peptides of placenta, very, very good results. We have a lot feedback about this. Exosomes, the one that mesenchymal stem cells derived, they help to promote osteogenesis and bone remodeling and improve the degradation, inhibit the degradation of the bone and improve the immune system regulation of bone turnover. Tissue engineering in biomaterials. It's technologies that suggest scaffolding. Scaffolding, the use of materials, and with this scaffolding techniques, the use of the stem cells. So that is why you can grow new bone tissue. It's also experimental, but quite successful therapies. Okay, here I finish my talk. Thank you so much for your attention.